Hello, everyone. My name is Lucie and it is my pleasure to welcome you to today's webinar, which focuses on women's experiences with iron deficiency anemia. Anemia affects 2 billion people worldwide, and the majority of those people are women. We develop anemia when our bodies don't have enough iron to make hemoglobin, a protein in our red blood cells that carries oxygen from our lungs to the rest of our bodies. And while anemia is quite common, it's often misunderstood. That's why we're going to spend the next half an hour or so unpacking the impact of iron deficiency anemia on women, its relationship with conditions like inflammatory bowel disease, and talk about how we might resolve some of the disparities we know exist in care. So today I'm joined by two experts and advocates for women's blood health to guide our discussion. First, we have Sherri Ozawa, who is founding member and past president of the Society for the Advancement of Patient Blood Management. She's also a member of the World Health Organization Working Group on Global Patient Blood Management Implementation. We also have Lucie Laštíková, who is chairperson of the Czech Inflammatory Bowel Disease Patients Association. She's also a member of an advisory board to the Minister of Health in the Czech Republic and a clinical trials ambassador. This webinar is produced by the Partnership for Women's Wellness, a recently established global collective of patient groups committed to bringing greater awareness to the burden of this condition and various other non-communicable diseases, and really raising awareness about how they disproportionately affect women. This partnership advocates for every woman to have access to prevention, screening, and early treatment because we believe that women's wellness is not just an afterthought, but a priority. We'd love to hear from all of you, so please use the Q&A function to submit your questions and comments at any point in our discussion, and we'll allocate some time throughout the webinar to address them. To kick us off, Sherri is going to give us an overview of the disproportionate burden of anemia on women and help us think through what some of those disparities in care are. Sherri, over to you.
Thank you so much, Leonda, for the kind introduction, and a big thank you to the Partnership for Women's Wellness for this opportunity to speak to a wide audience today. Just making sure everyone can see the screen.
Yes, we can.
Okay, perfect. Thank you. So, as was said in the introduction, we have a big challenge ahead of us with iron deficiency and iron deficiency anemia in women. It, as we heard, disproportionately affects women, but there are things that we can do about that. As healthcare professionals and as members of the public. And so I hope that after the next few minutes, you will have some of that information and then take some of it forward to empower ourselves and certainly those around us. So I'll take a moment to pause to say that as much as I am a healthcare provider with a long history in patient blood management, anemia management, and blood health, I'm also a mom of 4 children. And have experienced severe anemia, actually myself, untreated or undertreated and not quickly diagnosed. And what I've seen universally is that speaking to healthcare providers throughout the world, my female colleagues, even physicians and others involved in this field of blood health, have their own stories to tell about how we often overlook this as even those who perhaps know better as healthcare providers, and how that really has affected our lived experience, has actually affected how important we think this is and how we know it's important to empower ourselves and our patients for better health and wellness and actually global success. So we do have an issue across the world, as was mentioned in the introduction. There is a huge prevalence of both anemia and bleeding problems, and they are related. We don't have time to go deeply into all of this information today, but I'll hit it lightly. We know there's a lot of people on this planet, 8 billion, the world population is plus at this point. And we know that unfortunately, many people are dealing with anemia, about 1/3 of the world's population, again, disproportionately affecting women. and also another 13%, 600 million plus with bleeding disorders. And of course, this becomes a cycle when it comes to iron deficiency and anemia. There are many health problems that we can't completely fix or do too much about. And iron deficiency and anemia, we actually can do quite a bit about with empowerment, no matter what circumstances or what part of the world that we live in. And really, iron deficiency and anemia management is a disparity in healthcare, as was in the title of this brief talk I'm giving you today. And keep this, please, in the back of your mind as you think about what we're really talking about with justice. And here's just a little image of the differences between equality, equity, and justice. And all are important, but equality means everyone benefits and gets the same support. You can see three people standing on a box to watch a soccer match or football match, depending on where in the world you are. And then with equity, everybody gets to see the soccer match because they get what they need, right, to achieve this benefit. But really, social justice goes a step further and removes the barrier of that wall. So those are really where we have to get to as a goal with iron deficiency and anemia management, and remove some of those structural barriers that have so dramatically impacted women's lives. So again, 30% of the women around the world are dealing with anemia, even higher in pregnancy, and these may be even conservative numbers. And it is actually the number one cause of years lived with disability. You can search a lot online about exactly what that means, but it is an extreme burden on women's lives throughout the lifespan, and again, runs in vicious cycles. And there are goals set by numerous countries around the world, numerous health organizations, including the World Health Organization. And though there has been progress made in this area, we are still falling short of goals. And so I'm not really probably going to hear any surprise from the audience to know that it doesn't matter where in the world we are, women need iron, all people need iron, but the failure to have this issue of deficiency addressed, unfortunately, even more adversely affects folks in these darker regions of the world where perhaps there are more challenging economic situations. But even where the countries look like light gray, myself and many of my colleagues, as an example, where we in theory have access more readily to many resources, it's still a huge issue that affects our lives. As I mentioned, and I won't go into detail on all these graphics, they will be available to you later, but we have made some progress. If you look in the top right corner of the slide, since 1990, this gets measured by the World Health Organization and other organizations over years. We have made progress in the prevalence of anemia across the world, but we have done less well for females than males. And it really affects, again, women with a much higher, if you look in the bottom left corner, disability burden on their lives and their lifestyles. And of course, this becomes much worse during their reproductive years. So we have made progress. We have much work to do, but we can get some of it done. No surprises here, and I'll hit this lightly, but iron deficiency and anemia are not good for our bodies, anybody's bodies, but particularly women. From a brain perspective, certainly exhaustion, headaches, dizziness, many other symptoms. It puts strain on our cardiovascular system. It affects our immune function, which is not good for anyone, particularly in regions of the world where there are larger challenges in this area. And this profound exhaustion because, of course, at a very simple level, our bodies and most muscles need oxygen to function. And there has been a normalization of something that really is abnormal. So this slide really focuses on the idea of heavy menstrual bleeding or menorrhagia. During those reproductive years, that is really the primary driver of iron deficiency. So although we know that in many countries, that's certainly well published in both the public and the medical space, this often is treated as normal. And there are societal taboos, even in more developed nations, around menstruation, lack of education, women being gaslighted as a term that's used, or their symptoms are dismissed as just being normally tired because you're a mom or because you're a woman. And so this cycle of underdiagnosis and misdiagnosis continues. I was part of that myself. And then this generational toll, right? It isn't just that woman during that childbearing period of time. That maternal anemia compounds. Often women certainly may choose to have more than one child, or that may happen. That for that baby is a higher chance of adverse birth outcomes, premature delivery, low birth weight. For mom, higher risk of postpartum hemorrhage, which is, again, a huge problem globally, right? A leading cause of maternal death. And then we go through a cycle, right? Iron deficient babies born to iron deficient moms have problems throughout their life cycle. And again, we continue on and on with this intergenerational problem. And of course, this is larger. This is not just the individual's lifestyle, which is vitally important in the family, but this iron deficiency and anemia problem drive challenges and obstacles in families, therefore in communities, and therefore in nations. So this fatigue, the chronic cognitive impairment, women are not able to function at peak performance, whatever their circumstances may be. Of course, that contributes to economic insecurity, time left from work, reduced productivity at work, and again, a generational cycle. So these perpetual cycles are what we can break if we all work together at it. So again, a deep slide, you can analyze it in more detail later, but there are a couple of things that we can do. It is a crisis, again, of health equity and social justice. It is the world's most widespread deficiency, underdiagnosed and undertreated, but part of that, of these systemic barriers, I won't go deeply into this, but we have already set some inappropriate thresholds for measurement of iron deficiency, both with our hemoglobin and our ferritin testing. We have to re-look at that, particularly during those years of childbearing, because when we don't really measure the right way, we don't get the opportunity to even find this problem in many of the women we treat. And of course, many of these women are also dealing with other chronic and serious health conditions, as my colleague will talk about in a few moments, with inflammatory bowel disease and certainly renal disease and many other things that women around the world may deal with. So this cycle goes on, but we can break it. But part of that is the structural barrier of measuring this differently, more appropriately, and helping educate ourselves. And so this sort of this pyramid, this medical diagnosis, this ignoring of heavy menstrual bleeding and other things that are normalized that aren't normal, leads to geographic and economic inequity, structurally into the healthcare infrastructure, some patriarchal norms. So this is not just a matter of do people have access to nutrition, that's tremendously important, but actually becomes this larger manifestation of both poverty and patriarchy in many situations. So to finish up, this is something that certainly we as healthcare providers feel passionately about, but we also are very, very passionate that patients, women, have the need and the ability, no matter what their circumstances, to try to take charge of their blood health and have more information. That information may be more or less readily available in different parts of the world, but there's plenty out there. So again, not a lot, I'm not going to go into a lot of detail, but understanding what is not normal and not normalizing it, both with yourselves, your daughters, your sisters, your mothers, your families, and your healthcare providers, looking at alternative, we call them, but really fundamental treatments. Often women are put on oral supplements that are not as effective as they could be or should be, or compliance. Parenteral iron or IV iron, when it's available, is a great option. Many people don't even think of that around the world. So a lot of things that we can do, but making ourselves aware that there are many actions we can take. And there's a lot of activity all over the world online. This is just one example of a group that I'm privileged to be a part of, a World Anemia Awareness Community. There's a QR code on there. You can scan it. We have a day every year, but more and more people following this and interested from all kinds of groups and individuals around the world. And we hope that the movement gets louder and stronger because we can make women's lives healthier and better. And again, so thank you. This is about social justice, and I'm privileged to be here with you today and look forward to the rest of this webinar.
Thank you, Sherri. You shared a wealth of information, but what really strikes me is the description of, anemia as a crisis of health equity, and that it's a manifestation of poverty and patriarchy. And I think that's really quite helpful to think about this condition as a manifestation of deep-rooted problems that we need to deal with systemically. Thank you for that. So next up, we're going to explore how anemia is related to inflammatory bowel disease. And think about how we might benefit from improving blood health, expediently. Lucia, please go ahead. I think you're on mute.
Okay.
There we go.
And can you see my presentation now?
We can see it, but it's not in slideshow mode. Okay, it is now. Perfect.
Okay, perfect. So once again, thank you, and thank you for having me for the next 10 minutes. My name is Lucie Laštíková. I'm a chairwoman of the Czech Patient Association focusing on patients with IBD. But actually, when I will be speaking over my presentation, you can easily place any non-communicable disease in the place of the inflammatory bowel diseases, because with the chronic conditions, the issue with anemia, it's pretty close. What we do, just briefly about our association, we were established by the doctors, actually by the medical society, because they felt the need to spend more time with the patients, to dedicate more time outside of their offices, and to spread the proper education, because we were established in 2008, and it was the beginning of the internet in the Czech Republic, and not every information was valid. What we do is that in cooperation with those doctors, we are focusing on a certain topics. We are opening certain topics which are neglected within the diagnosis, and one of them is as well as the blood health and the need of proper diet and checkups regarding the anemia. And here are some interesting facts. Over 30% of our patients, not only women, but in general, the patients with IBD, they're claiming that they're experiencing fatigue even when their disease is in remission and they're not having any other issues. So the fatigue still stays. And what is the connection between the anemia and the fatigue? Well, the chronic fatigue is one of the main problems that the people with IBD or other inflammatory diseases are suffering, and it can be linked directly with anemia. I'm myself a patient with untreated anemia, undetected anemia, unless it was very severe and I ended at ICU. And I was actually suffering from all of these side effects. And only after I collapsed, it was detected that I am suffering from anemia. We have several types of anemia. Obviously, to be honest, the Czech specialists, they are still not aligned with the division of the anemia. If the primary cause within the IBD is the iron deficiency because of the blood loss, or is it the chronicity of the disease which is causing the anemia? So we are usually saying it's half and half, depends if you're having ulcerative colitis, which is more known for the increased blood loss, or if you are suffering from the Crohn's disease, which is affecting the bowel absorption. So if you remember all the symptoms I show you, when we are talking to patients, how they're feeling, if they're improved after they were discovered also being anemic, and how their disease improved, how their daily life quality improved when they received the iron IV. It can be even explained easily, because for me personally, I even remember my first IV when I got the iron. The next 3 months, I felt like a superwoman. And before that, I wasn't even able to imagine that I can actually improve so fast and to have such a high quality of life if I'm properly treated, not only for my primary diagnosis, but also for the anemia. What we are telling to our patients, that they need to prevent to get to the state which is severe for them. They need to be detected early. They need to do some preventive care. As you can see, dietary advices. We give dietary advices, and we are doing diet modification. But also with our patient, this is not enough, because the bowel inflammation, it's resisting towards the natural absorption of certain nutrients, and pretty much all of our patients need to be medicated. And also because of the absorption, the medication is usually not working properly. That's why we are recommending to iron administered by intravenous injections or IVs, because we don't want to get into the state when the patients need to be accepting blood transfusions. The problem between the diagnose is, and in my country, is the insurance, because for the drugs which are fully covered by the insurance companies, those are the first steps medication, which are usually not so effective, as my colleague already mentioned. And the more advanced treatment need to be paid, and they're not often offered to patients to be paid for. And I was very fast, I believe. So if you have more questions about how anemia is personally affecting the patients with IBD, or in general, what we can do with the chronic conditions and for the patients with the chronic conditions, do not hesitate to ask me.
Thank you so much, Lucie. I'm not somebody who suffers from anemia, but I know that for some people, when someone says that they're tired or that they feel fatigued, it's not taken with a level of seriousness. But I can't imagine needing to continue doing the daily tasks of life and perform optimally, even while you're chronically fatigued. I quite liked what you said when you were on medication. For the first 3 months, you felt like a superwoman. And I feel like every woman should feel like that. And I think it really compels us to think about an approach that helps us to address anemia and the different chronic illnesses connected to it more efficiently. Sherri, I'll start with you. You've worked in the space for about 3 decades, with a lot of your career spent developing academic and clinical programs to advance patient blood management. What are some of the barriers you've observed which hinder us from addressing the impact of anemia? You talked in your presentation about the need for health equity and the need for us to really treat the issue as a matter that requires social justice. But in addition to that, what would you say are the barriers that need us to pay really, really careful attention to?
I think on a large, thank you for the question, Leonda. And I think on a large scale, we in patient blood management are encouraging and publishing and driving the world to think differently about our own blood as our body's most important organ and natural resource. So we haven't really treated it that way. If you think about the history of how anemia or even bleeding disorders have been treated since the world wars in the 20th century, people immediately jump to the transplant of that organ instead of actually supporting its regeneration, right? So again, transfusion may be the appropriate therapy for certain patients, but it's much better to keep our blood in our bodies and keep it healthy. So that's the fundamental piece of what we are trying to push worldwide, which I think that if we can help people to start thinking about that blood is our body's precious liquid organ, then we think very differently also about iron deficiency anemia. Just the way we treat other organ failures, we treat them first, because transplant isn't always a resort. So I think what women will drive that change. So moving from that default position of transfusion and thinking about really the importance of iron deficiency anemia and bleeding management, because we're preserving the organ, and that's true anywhere in the world. So that's where we see really that equity occurring, is shifting everyone's understanding of actually our own blood.
Yeah, that's really helpful, because by the time someone needs a blood transfusion, it's often too late, or we're also putting a pressure on the health system when we could do a lot of work upstream, right? Trying to prevent and educate and protect ever needing a blood transfusion. Lucia, you did a wonderful job explaining the link between anemia and conditions like IBD. It's really interesting that you really simplified it by saying it's really that the body can't absorb iron because you have an underlying condition. I found the explanation quite simple. Is this link understood by patients and healthcare providers? If not, what can we do to empower these stakeholders to have better awareness of this relationship so we can address the condition more appropriately?
I think it's still neglected, but both by the patients and doctors, and it's mainly because the main symptom, the fatigue, is somehow ridiculed because it's very unspecific. They're usually reacting that everybody is tired these days because it's like either winter or early spring, and you're fighting the disease, so body is fighting itself. So it's not properly being checked. And even though we have doctors who are aware of these conditions, especially when you have a colitis and you are bleeding regularly, so they're prescribing you the medication, but then they're not checking if the medication is really working, because with those diagnoses, even though you're taking the medication orally, but you're suffering for severe diarrhea and you are bleeding from your colon, then the absorption is close to zero. So that's why they need to be aware that these types of medication it doesn't simply make sense to prescribe patients who are having a severe condition like that. And that's why we need to be more aware of the other possibilities, which are what I saw in the Q&A, that they're not accessible worldwide. So definitely it's an issue that needs to be addressed.
Yeah, and I think it also, motivates for the need for organizations like yourselves, which work with clinicians and patients to find common ground, common understanding of the issues, so we can collectively work on it together and draw from different chronic conditions to learn about how the conditions are sort of connected, so we can address them more holistically. So thank you for that. Sherri, you have a lot of experience, like I mentioned in my first question to you, but you've worked in academic research, clinical practice, and patient advocacy. Can you please give an idea what the benefits are that we stand to gain if we take an interdisciplinary approach to address disparities in care so that we can improve health outcomes for all women?
Yes, and thank you for that question, Leanda. We say that when we talk about patient blood management or anemia management, it's a multidisciplinary, multi-professional sport, but the patient is at the center, right? So we need to work together as teams with community involvement, groups of advocacy groups involved, certainly clinicians in all specialties. Again, blood unifies every organ system. Really, this collaborative care among different, both medical and administrative and nursing and pharmacy specialties with the patient at the center and the public are essential. There are many parts of the world, again, I'm privileged to work in this field around the world, where we see that nursing anemia management and iron deficiency initiatives are completely managed by nurses. So that may not be true in all parts of the world, but we may historically think about as being very medically centered, and our physician colleagues, of course, are extremely important, but nurses have a different type of training and are in many parts of the world both licensed and capable of a unique way of patient empowerment, patient education, patient engagement. So it's really about all of us. And I think that every single person on that team matters, and it should not be segmented into this is just for hematologists or just for gastroenterologists, because some patients have IBD, right? It affects every single part of our bodies and our health and our communities and our lives. So that multidisciplinary, multinational, community and all those things sound very idealistic, but we have seen progress. And so we can keep making progress if we think of this as we are all part of this. And empowering women in this area empowers the world.
Yeah, thank you for that. I love what you said about blood as the organ that connects all other organs. And so it goes without saying that the people working on the different organs in our bodies should be connected, working together to improve the state of blood health. Lucie, one of the disciplines that Sherri hasn't mentioned is clinical research. Women's bodies are still relatively under-researched compared to men. You are a clinical trial ambassador. I'd never heard of the term before. So please tell me, what was it about clinical trials and the way that they are conducted that motivated you to be involved in advocating in that space? And what exactly are you asking for? What do you want to see happen in the clinical trial space for patients?
So basically, I will start with the term clinical trial ambassador. The CTAs, we are a group of patient advocates focusing on multiple diagnosis who is helping patients to spread the awareness about clinical trials in general and also specifically for their diseases. And I started to be interested because of the personal reasons, because I was diagnosed very early with my primary diagnosis at age like 13 or 14, and I was battling the disease for over 20 years. And when I finally started to look for other options because I was failing all the types available medications, it was too late for me. I didn't fit any exclusion criteria, and I lost my bowel because of that. So then I started to be more interested about the possibilities because also we had the COVID period and general knowledge about clinical trials was widespread within the population. And I started to focus on our patients to let them know that they should use their possibilities wisely before it's too late for them, and also not to think about the clinical trials as the last option, because sometimes it can be for them beneficial to start way earlier. So basically, we are an international community of people who are focusing on multiple diagnoses and letting patients know where they can look for options and to get treatments which are not on the market yet, for example.
Yeah, thank you for that work, because I can only hope that over time it's going to contribute to us expanding access to clinical trials for women so we can understand women's bodies better and design interventions that address their unique needs more appropriately. My final question is to both of you. So the Partnership for Women's Wellness is adamant that patients are an invaluable asset in our advocacy. You're both committed patient advocates, like we've heard. You're passionate about the issue because you're patients yourselves and you're experts. You really, really emphasize the need to place patients at the center of blood health. So reflecting on your experiences respectively, can you please give one or two ideas or points of reflection on the value of patient voices in shifting policy and healthcare approaches? I'll start with you, Sherri.
That's a great question, Landa. And I think I sometimes try to compare our progress and our journey in blood health and patient blood management to other areas. Sometimes I compare it to infection prevention, as many of my colleagues know. And there was a time where healthcare providers might not, patients might not say to a healthcare provider or did you wash your hands? Right, even at a minimum. But now many around the world feel empowered to keep an eye on that because we know what infection can mean, right? Whether you're in the hospital or in the community. So we would love to see that kind of progress even in blood health and iron deficiency anemia management, where we don't just accept, well, I think I feel terrible, but maybe I'm just exhausted because I'm a mom. Understand, and again, there's different levels of health literacy around the world, and not all information is available as readily as we would like to everyone. However, where we can, and we can empower ourselves, our women, our patients, our communities, our families with that information to, and not push back and argue with their healthcare professionals, but advocate for our own bodies and say, well, you may think that number is normal, but I don't feel normal. I don't feel okay. And this is the effect it's having on my lives. And then where there is the ability to have that additional health literacy, understanding that what people have considered normal measures aren't actually normal. That's the structural part. And we will get there, I'm sure, hopefully in my generation, maybe the next to come. But push, again, not argumentatively, but pushing back what would be considered normal and asking the questions and breaking down some of these taboos around menstrual bleeding. And women we didn't get into it, but many have undiagnosed bleeding disorders because they don't know that it's not normal, because they've only ever heard from their moms or their sisters or their aunts who may also have the same problem. So be able to speak openly about this. And when we see that happen, we actually in real life, some of these taboos get reduced and some of these conversations happen, it educates both the healthcare providers, because patients can also educate their providers at any part of the world, and vice versa. So the more health literacy we can expand with nutrition, screening, understanding that what's seen as normal isn't necessarily normal. It's true in so many parts of life. Really, I've seen it powerfully impact all our patients, but especially women, where there's this gigantic opportunity.
Mm-hmm. I love this idea of an empowered patient that also educates or sensitizes their healthcare provider. It really speaks to how important it is for us to invest in patient education. Lucia, what do you think?
I can only emphasize Sherri's word. I just think that it literally doesn't start with the patient advocates. It starts with the patients and caregivers themselves, because they need to take the responsibilities in their hands and to be managers of their health. And then if they became professionals, they can also do the same thing for the adult patients and caregivers. And I am fully following the rule of the social participation. I believe that the patients and the patients' professionals, caregivers, should be included in all of the strategical processes through the whole healthcare system, and they should be advising and showing their sides.
Mhm. Thank you so much. We have three questions from our audience. I'm going to try and go through them as quickly as possible, but don't rush yourselves. The first one is from Samuel. He is actually a member of the Global Patient Alliance for Kidney Health, and he runs a kidney patient group in Malawi. His question is about the use of EPO as a recommended treatment for anemia. Are you aware of that treatment? Is it used in any of your countries? He's curious to know.
So I certainly can comment that. So erythropoietin is a hormone that the body naturally makes. It is now available in many countries. Can't speak for every single country, but many countries around the world created recombinantly. And it does, in a short explanation, stimulate our own bodies to increase red blood cell production. So there's a lot of information available online about it. It has a long history now, a few decades of use in medical settings, starting actually in renal patients and now have expanded in many settings. It is not something that's appropriate for all patients, like all the things. There are times and places where that's clinically appropriate. Regardless, it can be a powerful and useful tool as part of anemia management and optimization of patients. However, regardless, whether it's the patient's own endogenous, their own EPO, or something that comes recombinantly injected into them or delivered, however, they need the building blocks. So iron is the biggest one, right, to build hemoglobin. So this is certainly EPO is a part of that chain. And there's, again, lots of algorithms to show you where that fits in the patient's clinical journey. But we have to give the blocks to the EPO to work on in our own bodies, like iron.
Yeah, thank you. I like that you're going back to the fundamentals, which is the need for us to have more iron in our bodies, because really that's the micronutrient that does a lot of hard work that needs to be taken care of. We have two more questions in the Q&A box, but I think that it might be helpful for us to answer Aaron's question offline. So we'll make sure that we reach out to you, Aaron, and send you an email to answer your question. And there was another question about what we can do to improve the implementation of patient blood management. I think that in your responses, in your presentation, and in the Q&A that we've just had, you've sort of addressed that question, Sherri, but is there anything else you'd like to add?
I think that there's great information available because of the work that I've been privileged, along with colleagues, to do with the World Health Organization at that level now. There are blueprints out there. There are two documents specifically about patient blood management. First, the one I referred to, which was the call to action, sort of to say we have an issue and here's what it is. And then more recently, within the last 2 years, we have actually created an implementation document, which has modeling of what this actually looks like in both high resource or low and middle income countries, because everybody can do something. Not everybody can do everything with the resources they have, but the patients have the role, right? Healthcare providers, government systems, professional organizations, and there are models now around the world, or of different parts of the world, Central and South America, Mexico, Portugal, Spain. I can mention others where there really are structured systems with both governmental and private and patient support to implementing patient blood management on larger scale. So I think we are, we're not at the tipping point yet, but I think we're getting close to where this really becomes embedded and entrenched in healthcare delivery systems around the world. But lots available online about world development on that.
Thank you. Thanks, Sherri. Lucie, I'm going to put you on the spot. I know that you also work on developing material that helps with patient blood management. In your context, is there anything different to what Sherri just mentioned that can help us think about how we can improve PBM in different contexts?
Well, I would say that for us, it's specific to system we are having the general practitioners. And for adult people, we have every 2 year regular preventive checkups, and the blood withdrawal is it's part of that test. And we are asking now for the risk groups the period to be shortened for 1 year, so we have more relevant data, and the people are not suffering through 2 years without being regularly checked.
Excellent. Thank you so much. You both shared wonderful gems that I'd love to dig into, but we're running out of time. And so just to wrap up, I wanted to raise 3 key messages that stood out for me. The first is that we cannot underscore enough the impact of anemia on the women in our communities, biologically and socially. And we need to take seriously the fact that millions of women still go undiagnosed and undertreated. In fact, both of you had the same challenge. So in this sample, it's about 60% of women. The second is that we can't ignore the link that anemia has with chronic illnesses like inflammatory bowel disease. So if we don't identify the underlying causes of poor iron absorption, it's really difficult to address it adequately and protect lives. So we need to take more seriously the need to examine these underlying conditions and treat the root cause more effectively. The third is really that addressing anemia delivers benefits across the board, right? So I think there's a lot of conversation lately about the need to invest in women's wellness, not as a moral duty, but really as a smart business decision. Treating anemia effectively benefits patients, their families, policymakers, the health system, and society at large. It reduces morbidity and mortality. It takes a lot of pressure off the health systems, which are already overburdened. It boosts workplace productivity and improves population health. And the last but not least, it also yields economic gains. And it's the one thing we know policymakers like to hear is, are you making me money or are you saving me money? So thank you so much, Lucie and Sherri, for your insightful contribution, and to each and every one of you for joining us from around the world. We've loved your questions. We wish we had more time to go through all of them. We'll try and reach out to you offline to make sure that your questions addressed. You'll each get a recording of this webinar in your inbox, but if you're impatient, please go to our YouTube channel to find it and have a look. I encourage you to please share this link with everyone in your network. This condition affects a lot of people that we might know, and it's important for us to have a community approach to addressing it so we can support women's blood health more effectively. To learn more about blood health and various other health conditions, please go to the Partnership of Women's Wellness website, that is forwomenswellness.org. And don't be a stranger. Please connect with us on LinkedIn, Facebook, and Instagram for real-time updates on upcoming webinars, events, and publications. Until then, we'll see you at the next webinar. Goodbye.
Thank you.
Thank you.